Hello, this is Joan Hebden. I am an infection prevention consultant and research coordinator for PDI Healthcare, and I'm happy to be presenting a webinar to you on chlorhexidine gluconate, the IT Antiseptic. This was basically a term that Keith Kay, who is a professor of medicine at the University of Michigan, coined for chlorhexidine. As you all know, chlorhexidine gluconate is widely used for any number of interventions to reduce healthcare-associated infections. And we will be focusing on a couple of those uses during the webinar. The objectives for today's webinar are define the mechanism of action of chlorhexidine gluconate, understand the two modes of bacterial pathogenesis into the bloodstream from intravascular devices, define the uses of chlorhexidine gluconate to prevent central line-associated bloodstream infections, which again will be our focus in terms of indications for use today of this particular antiseptic, state the current CDC recommendations for the use of chlorhexidine to prevent CLABSI, define the mechanism for development of CHG resistance. This has become a concern with the wide use of chlorhexidine gluconate, and I do want to address some of both the in vitro work as well as some clinical evaluations of chlorhexidine increased resistance. Let's start by talking about the mechanism of action for chlorhexidine gluconate. I want to just highlight, before we talk about the mechanism of action, that this is a broad-spectrum topical anti-infective. It's active against both gram-negative and gram-positive organisms that are responsible for healthcare-associated infections, as well as fungi. The mechanism of action is basically one of which a positively charged chlorhexidine molecule is attracted to the negatively charged phospholipids in the cell wall of the bacteria. The chlorhexidine then binds to the cell wall, and this destabilizes the cell wall and interferes with osmosis. There is very rapid bacterial uptake of the chlorhexidine gluconate, actually within 20 seconds. Once inside the cell, there is a rupture of the cell as the cytoplasmic membrane is disrupted, and this results in cell death. The other thing I want to emphasize about mechanism of action is that chlorhexidine gluconate has shown some ability to inhibit adherence of microorganisms to surfaces, which prevents the development of biofilm. I think we all know that biofilm is an aggregation of organisms. It creates a matrix which actually protects the bacteria within and can contribute to resistance to antimicrobials. So this particular feature of chlorhexidine is obviously very attractive. I also wanted to highlight a paper that was published by Popovich and colleagues, where they looked at the relationship between chlorhexidine gluconate skin concentration and microbial density on the skin of critically ill patients that were bathed with chlorhexidine. And although we are not going to discuss specifically the use of chlorhexidine gluconate as a bathing agent during this webinar, I do want to highlight that the density of skin flora at an intravascular catheter insertion site is a major risk factor for CLABSI. And therefore, I think that there are some important takeaway messages from this particular paper. During this study, bathing with no rinse 2% chlorhexidine impregnated cloth was utilized, and patient samples were processed looking not only at chlorhexidine concentration, but also microbial colonization. The authors studied aspects of chlorhexidine skin cleansing by means of a colorimetric semi-quantitative chlorhexidine indicator test. And this has become widely used. They actually assessed various parts of the body, the neck, the antecubital fossa, and the inguinal areas at 1 hour before and 1, 4, and 23 hours after the bath. There were direct observations done of the bathing. The chlorhexidine concentration correlated inversely with the density of gram-positive bacteria on the patient's skin, and that is actually highlighted in the top figure, where you can see that the y-axis is the log CFUs of organisms, and your x-axis is your chlorhexidine concentration. And as the as you see an increase in concentration, you also see a decrease in the microbial density. In addition, the figure below is showing you that, in fact, there is very rapid reduction in microbial density with the initial sampling for gram-positive bacteria. And you see that that activity persists on the skin for up to 24 hours. So again, I think this is an important paper in that we would expect that the same effects would be seen at the site of intravascular catheters. Let's talk briefly about chlorhexidine applications as an infection prevention tool. The uses that have been FDA approved and have strong evidence of efficacy are identified here for you. The antiseptic is utilized as a surgical hand scrub. There has been data that has shown an 86 to 92% reduction in hand skin flora. It's used as a general skin cleansing agent. As we know, it has gained great popularity as a bathing agent with significant reduction in normal skin flora, gram-negative organisms, and Staph aureus. It's utilized as a preoperative scrub and has been shown to be superior to other antiseptics in reducing skin flora at the surgical site. And we know that it is considered the most attractive and recommended antiseptic for catheter site preparation for central venous lines, with some data showing a 49% reduction in CLABSI when you compare skin prep with chlorhexidine versus povidone iodine, and we're going to talk about that paper. There is also use of chlorhexidine with impregnation into the catheter dressings that are applied to reduce extrinsic contamination to the insertion site. It's been shown to reduce catheter colonization with epidural catheters, and it also is gaining usage as a intravascular catheter maintenance antiseptic to disinfect needleless connectors. So we will be focusing this webinar on chlorhexidine applications to reduce CLABSI for cutaneous antisepsis as well as catheter hub disinfection. The pathogenesis of intravascular device-related bloodstream infections is shown here for you. The organisms that can cause bloodstream infection are going to gain access to the device surface. They adhere and they become incorporated into a biofilm. The access to the extraluminal surface of the device occurs as a result of skin flora at the insertion site, as well as from the hands of healthcare workers who are inserting the catheters. And here the percutaneous tract is invaded. Intraluminal surface access to the device occurs through manipulation of the device by needleless connector that are placed on the hubs of catheters, and then the lumen of the catheter becomes contaminated. So in terms of preventing extraluminal entry of microorganisms or cutaneous antisepsis, it has been shown that chlorhexidine is superior to povidone iodine and should be the first choice for the insertion of vascular access devices. Here you have a meta-analysis that was performed in 2002. There were 5 randomized controlled trials which specifically examined chlorhexidine's role in the prevention of intravascular device-related bloodstream infection involving central venous catheters and arterial catheters. A meta-analysis of these 5 trials found that a chlorhexidine-containing antiseptic is superior to iodophores. Here you see the risk ratio of 0.55, indicating that there was a 45% reduction of these infections seen with the use of chlorhexidine over povidone iodine. Another paper that compared chlorhexidine to povidone iodine solution for vascular catheter site care. Again, you see here, and this is the paper that was cited earlier, that among patients with a central venous catheter, chlorhexidine gluconate reduced the risk for CLABSI by 49%. So this was further substantiation of the superiority of chlorhexidine to povidone iodine for skin antisepsis. I do want to take a moment just to go over the CDC recommendations and the categorization of strength of evidence as it relates to chlorhexidine used to prevent intravascular catheter-related infections. Here you see the categorization that is utilized by the HICPAC group, which is the Healthcare Infection Control Practices Advisory Committee. They are going to be looking for all of the evidence that has been published around a particular topic. And in this case, they have looked carefully at the studies that were focused on chlorhexidine as a cutaneous antiseptic and also for maintenance for disinfection of needleless connectors. But I'd like you to focus both on Category 1A and Category 1B. 1A being strongly recommended for implementation and strongly supported by well-designed experimental, clinical, or epidemiologic studies. And then Category 1B, a slight distinction here, strongly recommended for implementation and supported by some experimental, clinical, or epidemiologic studies, and a strong theoretical rationale, or an accepted practice supported by limited evidence. So we'll talk about each one of the recommendations for chlorhexidine use to prevent intravascular catheter-related infections. And here you see that the use of chlorhexidine for cutaneous antisepsis is a Category 1A recommendation by the CDC, and they specifically state that skin should be prepared with a greater than 0.5% chlorhexidine preparation with alcohol before central venous catheter and peripheral arterial catheter insertion and during dressing changes. Now, they certainly are addressing here the potential for allergy to chlorhexidine and stating that if there is a contraindication, that tincture of iodine and iodophore or 70% alcohol can be used as alternatives. I also wanted to highlight that the best practices checklist that is utilized widely for the insertion of these types of catheters does specifically include prepare the insertion site with greater than 0.5% chlorhexidine with alcohol. And additionally, there are some states that, along with the mandated reporting of CLABSI, also have mandated reporting of central line insertion practices. And this shows you that on the, what we call CLIP form, and the compliance with recommended practice, you see that if chlorhexidine is not the skin prep choice, there needs to be a rationale provided. Was there a contraindication to chlorhexidine? And then very specifically, they're looking for what that type of contraindication would be for that particular patient. Okay, so let's move on and talk about preventing intraluminal entry of microorganisms, or what has been termed scrub the hub. We know that there are a number of guidelines that have been published suggesting that disinfection of hubs before every access is recommended to reduce the potential for interluminal contamination of the catheter. However, optimal disinfectants and hub scrub time are not known. So here, although we have a Category 1A recommendation about scrubbing the hub, we do not have a specific antiseptic cited. In other words, we have here chlorhexidine, povidone iodine, an iodophore, or 70% alcohol. Access support only with sterile devices. But again, not only are they not specifying a specific antiseptic, they also are not specifying a specific scrub time or application time. However, in the UK, where they have a national evidence-based guidelines for preventing healthcare-associated infections called the FAPIC 3 guidelines, one of their recommendations is that a single-use application of 2% chlorhexidine and 70% alcohol, or if there is allergy, using povidone iodine and alcohol, should be used to decontaminate the access port or catheter hub. And they also go on to specify the application time, a minimum of 15 seconds, and allowed to dry before accessing the system. This is considered a Class D and a good practice point recommendation. A Class D recommendation in these guidelines states that it is based on non-analytic studies, and these would be uncontrolled before-after studies, case reports, or case series, or legislation expert opinion. Good practice point is a recommended best practice based on the clinical experience of the Guideline Development Advisory Points Group and patient preference and experience. So we have across the ocean, our colleagues there taking that leap of faith to indicate that chlorhexidine alcohol is, again, preferred, just as it's preferred for skin antisepsis for hub disinfection. As far as a summary of what exists in the U.S. In terms of clinical guidelines for disinfection of needleless access devices, they are covered here for you. You see the 2011 CDC guidelines at the top. We've already spoken about the recommendation related to scrub the hub. The Infusion Nurses Association in their 2011 guidelines, again, they are advocating for the use of a disinfectant prior to access of needleless connectors each and every time, but they are not specifying a specific disinfectant, nor are they recommending a specific application time. SHE, the Society for Healthcare Epidemiology of America, is actually, again, stating what has already been stated by CDC and the INS. They do, however, cite that alcoholic chlorhexidine may have additional residual activity compared with alcohol. And they are saying to apply mechanical friction for no less than 5 seconds to reduce contamination. And we'll talk a little bit about application times in just a few moments based on some current literature. The Joint Commission certainly is citing that there should be disinfection of catheter hubs and injection ports before accessing those ports or hubs. And then the Infectious Disease Society of America, here they're talking about blood sampling through the catheter. And they are, again, not specifying a particular disinfectant, but they do emphasize, and I will emphasize as well, allowing adequate drying to mitigate the potential for blood culture contamination. And then we also have guidelines related to the management of dialysis catheters. And again, you see no specific reference to a particular antiseptic nor a scrub or application time. So let's talk about what the current evidence is about preventing intraluminal entry of microorganisms through scrub the hub for chlorhexidine alcohol. These are in vitro and clinical studies that have been published. Okay, the first paper here is by Hong and colleagues. This was an independent study that was not sponsored by PDI. However, PDI is in fact the manufacturer of the 3.15% chlorhexidine 70% isopropyl alcohol product that is used in this study. The organisms that were utilized as the bacterial inoculum are those that you would expect to be causing bloodstream infections in hospitalized patients: Enterococcus faecalis, Pseudomonas aeruginosa, Staph aureus, Staph epidermidis, and Candida albicans. In this particular study, they used different swab times or scrub the hub times. They did just a very quick swipe, 5, 15, and 30 second scrub the hub. And they, in this circumstance, used a scrubbing with a back and forth twisting motion. They did allow to dry for 30 seconds, and I think that's important. So here's their findings, that swiping with alcohol did not adequately disinfect the needleless connectors, particularly when they were contaminated with Staph aureus or Pseudomonas aeruginosa. They did conclude that with a greater than or equal to 5 second scrub, the chlorhexidine alcohol and alcohol performed similarly, but that the chlorhexidine alcohol showed residual disinfectant activity for up to 24 hours. And I think it is notable that these authors did attempt to assess the persistence of the antiseptic. And they did find chlorhexidine alcohol to be superior, as would be expected. This is a paper that was just published in 2017. This is a research brief from the Infection Control and Hospital Epidemiology Journal. The authors are from Queensland, Australia, and they are affiliated with the Alliance for Vascular Access Teaching and Research, or what has been termed AVATAR. This is a group that works very, very closely with the Association for Vascular Access professionals. They compared 70% isopropyl alcohol swabs to 70% isopropyl alcohol impregnated caps, which, as I think we all know, are widely used currently in the U.S., to a 2% chlorhexidine 70% alcohol swab. They actually also investigated the comparative efficacy of the methods on 3 connector types. And they used different durations of application, much like the Hong study. And they did the back and forth twisting motion on the connectors for 5, 15, and 30 seconds. And it is important to note that for the caps, they were left on for 5 minutes. And then the connectors were allowed to air dry for 30 seconds. You can see here that, again, the bacterial inoculum was with organisms that we would expect to cause healthcare onset bloodstream infections in patients with catheters, Staph aureus, Staph epidermidis, Pseudomonas aeruginosa, and Candida albicans. And very importantly, I want to point out about this study is that they actually did it on 648 connectors. They divided those connectors up, and 324 of those connectors they pre-coated with sterile human serum. And this was an attempt to simulate what might occur in the clinical setting, particularly if you were going to be utilizing the device for blood drawing or for blood transfusion. They did find in this paper, and you can see that there is a table here that shows you on the left the without serum connectors. You see along the x-axis the different products. So IPA5 means that alcohol swab was for 5 seconds, then 15, 30 seconds. The IC stands for the alcohol cap, and then you see the chlorhexidine at 5, 15, and 30 seconds. So on the left, the connectors that do not have serum applied, or they weren't pre-coated, so 324 of those connectors, and then those that did get pre-coated with sterile human serum on the right. And then on your y-axis, you see the remaining microorganisms. And I think it's very clear here that even with a 5-second chlorhexidine swabbing, which would be the 2% chlorhexidine, 70% alcohol, that this particular decontamination technique outperformed other methods with or without human serum exposure. They did cite that the ideal method would be 30 seconds with the chlorhexidine swabs. I think the authors were right to note that poor compliance with swabbing could negate the efficacy. They did a very rudimentary cost-benefit analysis, and they did indicate that a change from alcohol swabbing to chlorhexidine alcohol would not be cost prohibitive in light of the expected outcome reduction for CLABSI. They also did note that for the connectors that were exposed to human serum, that the organism reduction was reduced by greater than 50%. And so they were particularly emphasizing that when you use connectors for the purposes of blood drawing or for blood transfusions, it is critically important that the proper maintenance be conducted. They did not go so far as to say that the connector should be changed at that point, but certainly that might be something that should be considered. They did not measure persistence in this particular paper. And then I wanted to highlight a paper that was done by Soothill and colleagues. This was published in the American Journal of Infection Control in 2009. They did see a fall in their bloodstream infections following a change to 2% chlorhexidine and 70% isopropyl alcohol for catheter connection antisepsis. A pediatric single-center before-after study was done on a hematopoietic stem cell transplant ward. Again, this is a patient population that I think all of us know are very vulnerable to the development of bloodstream infections. There's certainly any innovative technologies are going to be looked at to try to reduce the poor outcomes associated with catheter use in this population. Their primary outcome was catheter-related BSI, and they did calculate rates per 1,000 catheter days, and they compared their data to the year immediately before chlorhexidine was introduced, and then during the 9 months after its introduction. You can see from the table here that they cite their data for just the stem cell transplant ward, and then 4 additional wards that house hematology, oncology, infectious disease, and immunology patients. The CLABSI rate declined from 12 per 1,000 central line days to 3 per 1,000 central line days, which was highly statistically significant at p-value of 0.004. And I think it's also important to note here that they do cite their central line days for the time periods that they're citing, and that there was really no statistically significant difference in terms of the usage or the utilization of central lines. You also see here that they saw similar declines with introduction on the other 4 wards. Another clinical abstract, which was actually presented at ID Week in 2014, is this particular paper by Mary Hebden and group, where they did a randomized crossover clinical trial to compare 3.15% chlorhexidine, 70% isopropyl alcohol to 70% isopropyl alcohol alone. And they also looked at 5-second versus 15-second scrub time for routine disinfection of needleless connectors. This study was done in an adult medical intensive care unit. You see here that they had, out of 509 hubs that were assessed, 113 or 22% of those hubs were contaminated. There is not much in the way of description about those organisms, but it is anticipated that this will become a publication where that will be specified. You do, however, see that the use of the 3.15% chlorhexidine, 70% isopropyl alcohol prep pad was associated with less central venous catheter hub contamination when compared to disinfection with 70% isopropyl alcohol alone. You see the table to the left of this slide, which is showing you that the statistical significance, a p-value of less than 0.001, was achieved only for the shorter scrub time. So let's also look at some quality improvement projects that have been presented at professional meetings about the use of chlorhexidine alcohol for needleless connector hub disinfection. This is a paper by Duffy out of Children's Hospital in St. Louis, where they changed their port hub disinfection product in an attempt to decrease CLABSI in a pediatric ICU. The pediatric ICU had been unable to obtain their goal of 0 CLABSI rates. However, they were seeing that the NICU in the Children's Hospital had transitioned from a 70% isopropyl alcohol swab for 15 seconds to going to a chlorhexidine 3.15%, 70% isopropyl alcohol swab for the same 15-second duration, and we're having very good results. So they sought approval from the key stakeholders in order to trial the chlorhexidine alcohol swab in the PICU. They implemented the intervention for a 6-month trial, and they utilized a historical 12-month CLABSI rate for their pre-intervention baseline data set. Nursing received education on the use of the chlorhexidine alcohol swab prior to and 4 months following the implementation. Their outcome metric, they looked at CLABSI rates. They also looked at a process metric, which is very important in terms of compliance with the scrub duration. And they also did a qualitative assessment of nursing satisfaction with the product. Here you see their data. The CLABSI rates decreased from 2.8 infections per 1,000 central line days to 0.48 infections per 1,000 central line days. You can see that their table or their graph that they have here, they actually are showing you on the y-axis just raw numbers of CLABSIs. This is not rate data. And then you see across the x-axis your time periods. They did show that scrubbing compliance was consistent throughout this trial, and they actually went on to implement the chlorhexidine alcohol swab as standard practice for hub disinfection. And at the time of this paper being presented, they had gone 294 days without a CLABSI in the PICU. And they did conclude that collaboration with key stakeholders and implementing the new catheter maintenance protocol supported by the literature led to acceptance of the practice change. And again, here is some of their data so that you can see it in terms of months. Interestingly, the nursing feedback that they had, how effectively do you feel you can scrub the hub? We had 29% say partially and 5% not at all. So I think all of us appreciate that the nursing staff are running and doing many tasks throughout their day, and there has been some concern about the ability to comply, particularly with longer application times. 5-second scrubs, certainly, and I'm going to show you some data about that, appear to be effective. Do you let the hub dry after scrubbing? We have 3% that say never and 46% that say sometimes. I would again emphasize the importance of allowing the connector to dry, particularly with chlorhexidine alcohol, so that you don't have any residue, sticky residue left. This is a paper that was presented at a meeting of the Association for Professionals in Infection Control and Epidemiology, or APIC, at their Baltimore meeting in 2011. Janet Pettit is a well-known advocate for preventing CLABSIs in the neonatal population. And she, while she was alive, contributed widely to our knowledge about the use of chlorhexidine with very small neonates. You have some background here, but I do want to highlight a couple of these bullets. The use of chlorhexidine gluconate solutions, although they are considered best practice for skin antisepsis, for central line insertion and maintenance in the adult population. The FDA has not given approval and cite to use with caution the solutions in infants less than 2 months of age. She also highlights that the extended antimicrobial persistence of chlorhexidine alcohol is beneficial in reducing the number of potential dressing changes, preserving the integrity of the neonate skin. And then as far as the economics are concerned, they estimated the cost of a CLABSI in a neonate to be around $40,000. Their methods, they did an internal assessment of practices both for catheter insertion and catheter site and hub maintenance. They initiated the use of a 3.15% chlorhexidine, 70% alcohol for skin preparation for catheter insertion and dressing changes, as well as for hub and connector set disinfection. Here you see their results. They did annotate this particular graph with when they did particular things. They do have the incidence of their BSIs cited on the y-axis. And they do want to point out that the BSI criteria was per the Vermont-Oxford network, which is a neonatal database, and CLABSIs per CDC criteria. And so you see two different lines on this graph, with the red line being the criteria of Vermont-Oxford, and the gray line being the CDC CLABSI definition. They did achieve 0, and that was achieved for 24 months consecutively. They also noted that they did not see, they had 0 incidents of skin breakdown or erythema associated with the use of chlorhexidine. So their conclusions are here for you. They felt that the use of the chlorhexidine alcohol swab for disinfecting hubs and needleless connectors was the crucial intervention. And they feel that this particular project contributes to the evolving clinical evidence suggesting that chlorhexidine alcohol is the best practice for needleless connectors. And lastly, I wanted to highlight in the outpatient hemodialysis population, the project here that was done by Bren and colleagues out of Grand Forks, North Dakota. They have a high utilization of catheter use in this particular outpatient center. It's well documented that patients that have permanent hemodialysis catheters have a 7-fold higher risk of developing bacteremia than patients that receive AV fistulas. But in this particular center, they were exceeding regional and national percentages for the use of catheters rather than fistulas. They cited their data in 2007. They had 11 CLABSIs, which represented 1.7 per 100 patient months. Again, an unusual denominator to use, but that is what they utilized here. And then they saw that increase to 2.4 BSIs per 100 patient months in the first 4 months of 2008. In addition to that, they were seeing an increase in the colonization with multi-drug resistant organisms among their patient population. And they also observed, when they did some compliance auditing, that hand hygiene was being omitted between touching machines or when performing non-invasive procedures. They were not observing that environmental surfaces were being disinfected between patients, and they were definitely not seeing the scrub the hub disinfection that they wanted. So they did a bundle of best practices simultaneously, which are cited here for you, one of which was the transition to 3.15% CHG, 70% isopropyl alcohol for scrub the hub, hand hygiene, plus gloving prior to patient care and touching machines. And they also went to the use of chlorhexidine, gluconate, impregnated sponge dressings on exit sites of patients who were deemed to be high risk. Here is their data. They observed their catheter-associated BSI rate dropping from 2.4 per 100 patient months to 0. At the time this was published, this 0 rate had been sustained for 15 months. And they also cited cost savings associated with this reduction to be almost $500,000. They were able to reduce their use of catheters and increase their fistula utilization. So they went from less than a third to almost a half of their patients getting fistulas. They did see a stabilization of their MDRO colonization rate. However, they really did not see a change in prevalence. I do want to briefly address chlorhexidine resistance and whether or not there is clinical significance. There have been some in vitro studies that have suggested that chlorhexidine exposure may cause reduced susceptibility to antibiotics and biocides, and this would be through mechanisms of resistance similarly to what has been reported for bacteria. And there has been one paper where strains of Klebsiella pneumoniae, which again is a pathogen that can cause numerous types of healthcare-associated infections, displayed increased tolerance to chlorhexidine, again in vitro, and there were some genetic mutations that were identified. And one of the big concerns of these authors was that the mutations that were seen also resulted in increased tolerance to colistin, which I think we all know is sort of a last resort drug for patients that have highly resistant gram-negative infections. However, most scientists are stating that insufficient evidence exists at this time and additional studies are needed. I do want to point out, though, that some authors in the July 2017 ITCHG did attempt to look at whether or not they were seeing increased resistance to chlorhexidine among Staph aureus bloodstream isolates that had caused healthcare onset infections. So they looked at the healthcare onset Staph aureus bloodstream isolates prior to and after the implementation of facility-wide chlorhexidine bathing. And they tested them for chlorhexidine susceptibility over a 7.5-year period. Patients were being bathed with a 4% chlorhexidine. There were 2 time periods preceded by at least a year of non-chlorhexidine use in this analysis. They did not observe a decrease in chlorhexidine susceptibility. The minimal inhibitory concentration testing was based on national clinical laboratory standard guidelines. None of the isolates tested contained resistance-promoting genes that are associated with chlorhexidine resistance, and this was assessed via a PCR detection method. They concluded that the broad use of chlorhexidine in hospitalized patients does not easily prompt the development of resistance. So I'm sure that we are going to see more papers like this as time goes on. Additionally, I know that there are some investigators that are looking at whether or not the same benefits, reduction in bloodstream infections can be achieved with less frequent use of chlorhexidine bathing rather than daily bathing. So in summary, chlorhexidine gluconate's broad spectrum of antimicrobial activity makes it an ideal agent for many infection prevention applications. The rapid antimicrobial activity of chlorhexidine with alcohol, in addition to the persistent and residual antibacterial effect on the skin, has led to strong recommendations for its use as a cutaneous antiseptic and catheter hub disinfectant. And there's more research needed to evaluate the clinical significance of chlorhexidine resistance to antibiotics. I'd like to take any questions and thank you for your attention. I do want to point out that there is a link here on this slide. We do need you to go to this link and complete a survey in order to receive your CE credit for having listened to this webinar. Thank you very much.